Hi, everyone. It's Dr. Tofi. Welcome to Hernia Talk Live, our weekly Q&A. My name is Dr. Shoenfeld Syndrome. I am your hernia and laparoscopic surgery specialist. Many of you are joining me live on Facebook at Dr. Tofi or via Zoom. Thank you very much. We have a special guest today and therefore also a special time earlier in the day to accommodate for our lovely friend and surgeon coming to us straight from Germany, Dr. Ralph Lorenz. You can follow Dr. Lorenz on Twitter, but he doesn't post on Twitter, so there's not much to follow. But please welcome Ralph. How are you?
I'm fine, and thank you so much, Shirin, for your kind invitation. I'm really happy to talk today about something like, of course, pure tissue repair or tissue repair.
Yes.
And that's a very, very exciting topic. And yeah, I'm right now during a German hernia conference in Cologne. I'm not at home in Berlin.
Yes.
My home is in Berlin, and I'm in a private practice and as well in a hospital very close by in Berlin. That is my professional address.
Yes. So the German Hernia Society meeting is currently on. As you know, we have multiple Hernia Society meetings throughout the year, all over the world. Germany is one of the foremost countries in terms of advancements in hernia. So many of the hernia techniques were invented by German surgeons. The history there is just really, really strong. And rightfully so, the German Hernia Society is also very active, very strong. So before we started, you were explaining to me how you have not only just the regular society meeting, but you have a lot of education, which includes cadaver labs and something called the Hernia Compact, which I think is a fantastic course. If you want to explain what the Hernia Compact is, and that's compact with a K in true German fashion.
Yes, Hernia Compact is right now, I think we have the 17th compact course right now already.
Yes.
With almost 40 to 50 young surgeons, participants. And
Wow.
this course takes normally 3 days. The first day is going back to the anatomy, which is crucial for all the hernia surgeons.
Yeah.
The anatomy is so important, and of course, so it's definitely mind-opening and eye-opening in every direction, and that's quite good. We do cadaver operation, we do cadaver demonstrations, we do ultrasound, we do simulation training on the first day. The second day is hands-on training with different hospitals or in different hospitals in this area. And the third day is lectures and a very controversial debate on it for having a wide discussion and a wide debate with young surgeons to attract them and to make them enthusiastic about this topic.
Yeah, it's fantastic. I've been involved with the Hernia Compact, and in America, in the United States, we try to mimic it. So we do have certain compact type courses. You've been part of it with the American Hernia Society. It's not the same. I don't know why, maybe because we don't have the history. But importantly, you do teach tissue-based hernia repairs as part of the cadaver, of the lectures and also the cadaver lab.
Yeah, absolutely. It's important to stay open-minded in every direction. And of course, we have a lot of requests, and that's something what we will talk in the next hour about with concerns against any foreign body and whatever. And of course, there are good indications in my mind.
Yes, and I think so many people that I see on social media are so concerned that we are not teaching our residents and young surgeons how to do tissue repair. In the United States, I know very few surgeons that do tissue repair, or at least do it well, I should say, enough that I would say, yes, go to this person or that person. Some of them started at the Shouldice clinic and then moved to the United States, so that's helpful. Others like me just have a special interest and have learned the anatomy over years, but it's very few of us.
Yeah.
And my residents get taught it because I teach them. But most residencies in the United States and probably other places in the Western world do not teach tissue-based repairs as you have to learn about it as part of your board's examination. But if you ask who's actually done one, I would say most will say zero.
I think the same in Germany. I think, of course, we have the same situation.
Yeah.
Of course, I train a lot of residents right now since a couple of years, also with the University Hospital together. And of course, they are enthusiastic about this. And of course, they are going a bit back to all these open techniques.
Yes.
And to learn the anatomy, of course, by examples and with getting a routine on it. And that's really, of course, highly motivating them.
Yes.
Yeah.
I think most people who are watching this probably know what a tissue-based inguinal hernia repair is, but do you want to just clarify what we're talking about?
I think, of course, pure tissue repair avoids the use of any foreign bodies during the surgery. Of course, we are suturing, and the most, and in my mind, most important thing is, or difference is that we make a reconstruction of the abdominal wall. That has, of course, his benefits. We talk since almost 30, 40 years about tension-free repair, and that makes a bit the difference. It's not completely with a lot of tension, but with a minimum and on tension, and even more on reconstructing the abdominal wall. And if you are even younger, if you are even more active, the reconstruction of the abdominal wall matters even more.
So just to clarify, in children, so I would say under 14, 15, it's standard of care to do some type of tissue-based repair. But as they get older, mesh seems to be more involved. And the techniques for tissue repair change as you get older. Would you agree with that?
Yeah, absolutely. Yeah. Of course, in the childhood, you normally only do a ligation of the hernia sac.
Yes.
That's it. Sometimes you use some resorbable additional stitches to close the defect in this thing. But secondly, in the, of course, elderly or even adult people, we use different techniques. And the most important or the most famous one is the Shouldice technique.
Yes.
And that is the technique which is also best evaluated since many, many years. And it's also included into the guidelines as the best method, which is, of course, where we have the best scientific research on it.
Yes. And the guidelines are the European Hernia Society guidelines that you're talking about, which are very important. They're updated on a regular basis. You're part of that team. And it's it guides a lot of us. And I wish that more US surgeons knew about it and understood it and followed it, to be honest. Sometimes you wonder why people do what they do, because it's definitely against the guidelines.
No, normally, of course, I think in the, since almost 20 years or something like this, of course, the Cochrane database make the basis of course, the recommendation for using a mesh every time.
Yes.
Right now, we are going a bit back, and in the actual or right now prepared update of these guidelines or international guidelines, there will be written that, of course, pure tissue repair is also a possible method to treat hernias. Mesh reduces a bit the risk to develop a recurrence, but there are other benefits on the other hand for speaking for the use of pure tissue repairs as well.
Yeah, and I'm glad they're moving in that direction, because up until now, it was a very one-sided view of what's best for patients. Were you there when I gave my kind of analogy of was it at this EHS? I'm not sure, but I gave an analogy where I said, when people talk about mesh versus non-mesh repairs, every single study shows mesh is better for recurrence. And that's true. Every single study will show, for whether it's belly button hernia or it's a inguinal hernia, if you use mesh and you compare mesh to no mesh, mesh always wins for recurrence.
Yeah.
However, that's like saying, if I go from point A to B by car versus walking, it's always going to be faster by car.
Yeah.
But in certain situations, you shouldn't be driving a car to your neighbor's house, right? It'll be faster probably, but you should just probably walk that one, If it's raining outside, maybe it's better to use the car and not walk. If you have a lot of heavy luggage to take with you, maybe take a car. But if you're just walking, maybe in some people, even a block is better to walk than drive a car. But if you break your leg, you should drive the car. So there's nuances to that. But if you always say car versus walk, it's always faster by car.
No,
but car is more expensive. Car,
yes.
you need to, it's bad for the environment. You can get killed in a car. Like, it has its risks too, right?
Then normally, of course, both have benefits on different areas.
Yes.
And that's the truth. And of
that's
course,
important.
we keep a balance even more between, of course, the big variety of possibilities. And of course, there's, we should not make the mistake to mix all the hernias.
Yes.
I think we have such a big variety of hernias, and that matters because we mix the different types, the different sizes, the different ages of the patients. And so for that reason, we need more than only one technique. One doesn't fit all.
So I have a patient that came yesterday. He traveled to see me. He's older, like 70 something, like 78, I think. Very fit, very thin, super thin. He has a very small hernia on one side and a scrotal hernia on the other side. And he's like, I don't want mesh. That's why I'm coming to you, because you offer that. And I said, okay, for that side with the small hernia, no mesh, perfectly fine. The scrotal hernia,
it could be a challenge.
we could discuss it, but it wouldn't be my first choice, right? So
normally, of course, I think the scrotal hernias are almost in the majority indirect hernias.
Yes.
And sometimes the scrotal hernia sac is huge, but the defect is small. And so that gives you a chance sometimes, because indirect hernias, as we know from the scientific research, have a low risk to develop a recurrence. And that's, of course, you should keep it in mind. I think I try to navigate my patients a bit more, that I do my previous ultrasound, dynamic ultrasound before I do the operation, to navigate what is the content, how big is the size, is it even an indirect or even a direct. I try to exclude any femoral hernia. And that's why I do always, in all cases, the ultrasound
because you do the ultrasound in your office.
Yeah.
And you also do the ultrasound yourself, because other doctors or radiologists are not as good for hernias.
Yes, I think, of course, when you do the operations, you know the anatomy very clear, and you have, of course, the best possibility. And the ultrasound is so helpful, because you want to know, exactly where you should have to look for, what details are interesting, and you have all possibilities to get more information before you start with the operation.
Well, the radiologist called me and said, we want to make sure that we're dictating these correctly when we're reading the hernia ultrasounds. Do you care how big the hernia is, or is it really the muscle opening that you're interested in? I said, if you want to choose, I really want to know the muscle opening, because how much content goes through it is not as relevant. I can see that, right? And it doesn't affect me so much in my surgical technique as does the actual neck of the hernia. But most radiologists tell you how big the sac is. I don't care how big the sac is.
Of course. I think the defect matters even more.
Yes.
And secondly, of course, you get even more information about how thick is the muscle, what proportion do you have, is there a lot of subcutaneous fat or whatever. You get so much information, and you can get even much more, and you are much better prepared for the operation with this knowledge.
Yeah, very good. You know, you mentioned Shouldice, among others. One of the questions that was shared with us is, so we have Bassini, Marcy, McVay, Shouldice, Desarda. What other techniques for tissue-based inguinal hernia repairs are there? You know, there's a whole book on them. It has probably hundreds of techniques.
Yes, I think
these are the most
are
common.
A lot. Yeah.
There's the Nihus Condon.
Of course, I think Shouldice, McVay is something which is definitely even more for the femoral openings. If you have a small gap in the femoral canal, you can close it with the McVay repair. The Desarda is a quite very interesting technique from India. And I know Desarda personally, and I have a very close contact to him. I invited him also to Europe, and so he presented this technique, which seems to be a bit more easy to learn comparing to Shouldice.
Definitely.
You are using a flap, which is an interesting technique. Of course, the origin is even much older, but I think Desarda is a very good alternative. It's not very well in research represented with long-term follow-ups. That is the major concern. That's why it's not yet included. But there is a door open already that Desarda seems to be might be the next technique. Bassini, if you do it even in the original technique, it's quite good, definitely. Yes. And Marcy is something what you use normally in the childhood or even in the adolescent patients. And the results are also even good. The Marcy repair has some, in the last couple of years, some long-term follow-ups, which are definitely optimistic, and the rate of recurrences is very low. But we
don't see a lot of adults that have recurrences from their childhood hernias. We don't see it that much. They're usually absolutely. Primaries. And then for women, small hernias of women, sometimes the Marcy works well too. Yeah,
absolutely.
And
of
then
course, there are some more techniques with, I think, which are in different areas of this world popular. And secondly, of course, one of the most newest technique came from South Korea, the so-called Kang technique.
Yes.
Might be that you have heard something about this already.
Dr. Kang. He's on. He's on HerniaTalk.
Yeah. And
what do you think of his? It seems like a modified Marcy.
Yeah, it's a modified Marcy, and of course, the difference is only that you don't make in a vertical direction the sutures. You use it in a horizontal direction, and that makes the difference. And it's quite interesting, and I'm looking forward for the first results. But it's brand new. Yes.
Yes, I think he's been saying that he is improving it. So his original Kang repair has changed a little bit. He's changed the type of sutures he's used and the directions and so on. But yeah, maybe I should interview Dr. Kang for one of my just to learn more.
No, of course. I think there is some progress on it, and also not only some slightly small interest. We are not the hummingbirds in the hernia world, it looks like it's getting a growing society which has interest on it.
And the Desarda would be for non-scrotal hernias, because the external oblique aponeurosis is destroyed usually in the larger hernias.
Yeah. Normally, of course, I think I just think about the topic, which technique is ideal for which hernia. And that would be, of course, beneficial for all of us when we choose, of course, the optimum for, I think, the type and size of hernia. And I got the impression that the Desarda repair is something, if you have a posterior wall weakness and a very thin conjoint tendon, and then it's very supportive to use the external oblique if it's not tears out, or if it's not tearing out, or is divided into different fibers, then you can use it if it's even strong, the external oblique fascia, to cover it on top of the posterior wall. That's beneficial, and it's very wise.
So it's a 2-layer repair.
It's, of course, you close the posterior wall, and then you make the flap on top, and then you come on top of the spermatic cord or round ligament with the external oblique again.
Oh, got it. Yes. So it's like external and then another one like that.
Yeah.
Got it. Got it.
Yeah.
Here's a patient that's got, I guess, had multiple surgeries. So he says, I've had roughly 8 surgeries and I'm trying to fix the pain from my left inguinal hernia. I started having more pain after the initial surgery to fix the hernia, and I have since had many different operations to help. Hernia revision, hernia revision, and I even took out all the mesh altogether, but the pain is still there. Any abdominal stress tends to worsen the pain. Also, I know ahead of time when I need to make a bowel movement because the left side tends to get much worse before I do. Even stronger sharp pain. So he can feel the bowel movement before because it's left groin pain kicks in. I've been to many doctors, but I'm now at the point where every one of them tells me all they can do is go in and take a look. So is there any advice you could give to me?
It sounds a very complex case.
Yes.
And normally, of course, the advice is, of course, first, make a very good or clear diagnostics to exclude all the differential diagnoses which can happen and have an influence. If you have already a mesh implanted, of course, that change the physiology of the abdominal wall and also the tendons and the muscles in the hip area. So for that reason, of course, please exclude all the other things which could be. I think there could be a tendonitis, there could be a muscle-related pain, there could be a back pain which going into the groin.
Yes.
And if you have any hip imbalance, that makes stress in this area. And that's very important that you make the examination not only concentrating on the hip or even the groin area, you should include the whole body into this examination. So because sometimes you have a problem already in the feet and in the knees, and you can realize that the problem in the more upper areas might has a relation to the other parts of the leg or something like this. And secondly, of course, the previous operations are very important. What type of hernias do they have? What size of hernias? How do they fix the mesh?
Details.
Yes, the details. And of course, it's a huge analysis in this thing, and to avoid any secondary operation without any, of course, intention. What could it be, and what could help for them?
Yeah, I never like it when a surgeon says, I'm just going to go in there and take a look. Because first of all, that's not without risk.
So
much can be learned by imaging before surgery.
Yeah.
Almost everything can be predicted by imaging before surgery.
Yeah.
So if you have a surgeon that just wants to take a look, I'm not a fan of that at all.
No, I totally
Also,
agree.
yeah, and also, don't you notice the people who say they have groin pain right before a bowel movement, they usually have a hernia. So this could just be a simple hernia recurrence or an unstable tissue repair that's presenting like a little mini hernia, right? I feel like if they say, I know I have a bowel movement before I have the bowel movement because my left groin pain starts, that usually to me tells me that there's a hernia recurrence or a weakness in the area.
Yeah.
What do you think?
Yeah. I think, of course, I totally agree. And of course, so we should not only concentrate on the groin, we should
Yes.
exclude or include the diagnostics into different areas, and also might be a colonoscopy or something like this could help in these cases. And of course, imaging is important, and mapping if you have some pain to get the dermatomes where the pain is, where you have a numbness and something like this. That's important, and the preparation gives you already a lot of answers.
I had a patient who had a hernia repair for groin pain and then had chronic pain radiate to his inner thigh, testicle. He had mesh removal, triple neurectomy, didn't work. He came and saw me. And you know what he had? Oh, he had multiple like nerve blocks, and then they put an implant into his back for pain. You know what he had? He had an autoimmune sacroiliitis. So it's also called ankylosing spondylitis. So it was always a sacral, like a back issue, but it caused symptoms in the front. And he probably never needed the hernia repair. Definitely didn't need all these other operations after that. And once he was treated for that, all his pain went away.
I totally agree with you. One of the most common things are even the sacroiliitis, and also the iliopsoas muscle, which is related in the deep groin area, and that could be very easily physiotherapeutic treated. And of course, it's definitely, I think these problems are very, very common. And if you have any kind of imbalance, and of course, that's why I look for them in standing position, in laying position, and examine the hip as well. If they have a symphysitis or something like this, such cases, like you told me, are very common. Of course, they have pain in the groin, which seems to be not really related to a hernia. They get a mesh repair or even something. The pain is after the surgery the same like before. So they get a second surgery. Once again, we will only want to have a look on it, but they put another mesh from outside. And then you have two meshes already inside.
I've seen those patients. Now that's even worse. And now it's like cardboard. Their whole groin is now cardboard. I had another patient yesterday. Probably his groin pain was not from his hernia, and he had a varicocele, a very large varicocele. So they fixed his hernia. The mesh actually probably made the varicocele worse. So he's had multiple surgeries now for the varicocele, and now it's a disaster. And he came to me, he's like, I think it's the mesh. I'm like, no. You have a serious urologic problem. The mesh didn't help, but the primary problem was all urologic. And I set him up with one of our specialists. Here's another question. Someone's asking, what are your thoughts about mesh? Are you still using mesh as needed for certain patients, or are you completely opposed to mesh and polypropylene versus polyester and PVDF, and all your other thoughts on those?
I think, of course, we use meshes, definitely. And I'm definitely, I try to navigate my patients into the group which need meshes because they have any kind of collagen disorder, which will never be treated by a pure tissue repair. I think we should select the patients, and that is the main address and the main take-home message for me. I think not everybody is using or need a match. But we have a group of patients, they have this collagen disorder. They are even older. They have, I think they are between 60 and 80 because they have such a, I think, collagen disorder or even weakness of the posterior wall. They have almost, in the majority of cases, direct hernia or even a combined hernia with a direct component and secondly an indirect or even femoral component. And these cases, or they have a multilocal hernia also on the opposite side,
yes,
or even Spigelian or even femoral obturator, something like this. So I think, of course, we have these patient groups, but I'm really try to concentrate who needs really a mesh and who not.
Yeah,
and,
very true.
Yeah.
There's another question that was presented, which is, how do you think of the different tissue repairs? Is there one that is maybe less invasive, has less recurrence, less short-term pain? All the studies point to Shouldice being superior, all things being equal, but, and you mentioned, in children, we tend to use like a more of a Marcy or just a high ligation of the sac. But what are your thoughts on the different tissue-based repairs?
I think in the outcome of all these tissue-based repairs, I couldn't identify a lot of differences. I think they are almost very similar. Also, what is the time to rest after surgery seems to be similar. We have patients, they, of course, they can do whatever they like immediately after surgery.
Yes.
And like me, but when I got my Shouldice repair, I went home on the same day. I went up to a hill on the same day,
yes,
which is useful because we have used the long-term resorbable local anesthesia additional.
Oh yes, you didn't know what you were injuring.
Yes, and normally, of course, I think the pain was minimal.
Yeah, can I ask who did your surgery?
Who did it?
Yeah.
No, of course, a friend of mine who's really familiar with Shouldice, and I can tell you the story that I fixed his hernia in the other way around in the same way, and he was in the same way satisfied.
Very good.
Yes.
Yeah, I feel I don't have hernias, but I did get imaging, and there is a little bit of fat in my inguinal canal. I don't have any symptoms, but I know it's there. So I'm always, and it's bilateral. So I'm always thinking, it's bilateral. What if I need a hernia? Who would do it? And what technique?
Of course, if you have only some fatty tissue, this is something which is definitely almost common, that you have along the round ligament or along the spermatic cord, some slightly small tissue, some fatty tissue. Normally, of course, is it a hernia, a real hernia? No, they have no peritoneal
not yet.
Nothing. Yes.
Yeah. Okay, here's another question about weightlifters. So I've had this question come a couple times. What are your thoughts on hernias in weightlifters? Oh, stop share. Hold on. What are your thoughts about hernias and weightlifters? And do you think there's a preferred technique to repair them?
No, I think what really matters is I think the size and the type of hernia and the age of the patient. Once again, I have one example which is definitely famous because he was the winner of the Olympic Games in weightlifting.
Oh,
and he has a kind of course, remaining pediatric hernia.
Oh.
And for this reason, he got only a pure tissue repair, which was and finally, of course, he's still active.
And, I mean, I don't see, I've had maybe one, had a wrestler, but I've never had like a professional weightlifter. I don't think they get hernias disproportionately. They may actually have less hernias. What do you think?
Yeah, I strongly believe. I have to switch on the light. Sorry for this.
Well, because you're in Cologne, Germany, and it's like 9:30 p.m.
Darkness.
I appreciate it.
So I think, of course, we try to. There is no difference between the different techniques in regarding sports activities. If you are even more sports active, a runner or triathlete or whatever, I would avoid any foreign body. I think I know all the sportsmen are much more sensitive to.
They can feel everything. Yes.
They feel normally, of course, all the foreign bodies, and that makes a slightly difference.
Yeah, I feel the more athletic you are, any little imbalance, tightness on one side more, or hernia on one side more, they absolutely feel the imbalance. It's so interesting.
Yeah, absolutely.
So for inguinal hernias, you think a tissue repair for a weightlifter, or mesh repair, or it depends? You don't think it makes a difference that they're weightlifting?
I think the weightlifting, doesn't matter.
Yeah, I agree.
I would look for the age, the type and size of hernia, and that would help me in regarding the decision how to treat, how to fix this hernia.
I agree. What about the belly button? That's a different story.
The belly button is something which is different. Of course, the pressure in the abdominal wall, in the umbilicus or epigastric area, is much higher than in the groin. So for that reason, of course, there is slightly, depending on the size of the hernia, both possibilities are of course possible. Normally, of course, in a very tiny, small hernia of 1 centimeter, the majority of surgeons would fix it by suture.
Yeah, agreed.
That's it. But if you have a rectus diastasis, and that is something which matters even more than only the size of the hernia, then you should choose a mesh. Yes.
Yeah, agreed. This is a question I get asked a lot, which is, let's say you had a tissue repair and now it's recurred. So is mesh always the next step?
That's an interesting question, because
these are all my audience. These are all audience. I had nothing to do with these questions. Audience submitted.
No, normally, of course, I would be very critical for the first repair if it's not done by an expert. The quality is very different, and so for that reason, my first choice or my first recommendation would be, please send me the operation note, that you get any information. What have they used? How do they made it? How do they follow any standard protocol of these techniques or not? And sometimes I can read already, of course, they have used resorbable sutures, they have used only a 2-layer repair instead of a 4-layer repair. Then I know, okay, we should look intraoperatively, what is the quality? And if you have done previously, might be, for instance, a Shouldice repair, and it's a recurrence after that, you have one option with the Desarda. That could be one option.
True. That's actually a good option for Desarda.
That's a very good option if you want to avoid any foreign body. That is one main thing. Sometimes we have also a lot of recurrences after previous or index operation with mesh. And then it's definitely also an option to use a pure tissue.
Yeah, so I think the typical scenario would be they had, let's say, a strangulated hernia. They went to the emergency room. The surgeon did bowel resection, et cetera. They did a tissue repair. So not an ideal tissue repair, but still that tissue plane is destroyed in some ways. Then if that recurs, which is probably the highest chance of it, you're saying that you may take these patients for a tissue repair. In some cases. You won't always say no.
Yes.
And do mesh. Yeah.
No, I would not generally answer that they need always a mesh.
Yeah.
I would look for the details. I would look for the quality of the index operation. I would look for what do they have used? What is the quality of tissue? And something like this. And then you get, might be intraoperatively a decision, which is, of course, experience-based even more.
Yeah.
But normally, I think I don't exclude it only by the data that it was a recurrence.
Agreed. Yeah. It's actually a good option for Desarda. I never thought of that. You know, those of you who follow me know that I've never been a big fan of Desarda. Part of it is that the way it's been rolled out has been not without much strong evidence. And the second reason is because my mentor, when I used to work at USC, he trained in the 1950s, and he remembers a similar repair that was being done, and they abandoned it because they had a high recurrence rate. So those two data made it so that I never really took upon the Desarda technique. But I think in this situation, it sounds like the ideal tissue repair option. Yeah.
I think, of course, I give you an example because yesterday we have in the cadaver workshop here in in Cologne a case. One side was originally there was no previous operation, but on the and we did an open preperitoneal. On top, we do a Shouldice and as a third layer or third stability for training issues. We did a Liechtenstein on one side. On the other side, we could identify during the surgery that there was already a Liechtenstein made before. We didn't know it. And of course, they opened the floor and there was a mesh already. And so for demonstrating, we tried to make a Desarda repair on this side. It works brilliant.
It worked? So you were able to lift the external oblique off?
Yes.
And preserve it enough to bring it down. Yeah, I can see that. Yeah.
I think, of course, Desarda is something which is a bit more upcoming. I think there are even more studies right now. And in the last 5 years, and also in the last 1 year or 2 years, we get even more publications on this topic.
Yes.
And they compare not only Liechtenstein with Desarda, and they are even very comparative. And so I think there is not a huge difference. And so for that reason, you can avoid with this autolog mesh any foreign body.
Question about stainless steel sutures. So the original Shouldice repair is described with stainless steel. What are your thoughts on that? I know currently even the Shouldice hospital is agreeable to using proline suture instead of stainless steel. But what are your thoughts on that? Is it a good idea? Not a good idea? Does it break? Does it prevent you from having an MRI? What's the thoughts?
No, I think, of course, the stainless steel is historically, of course, the original technique from Shouldice.
Yes.
We did in 2019 this consensus meeting in Hamburg, and invited also the son of Shouldice and also different important persons from the Shouldice hospital. And they agree on this issue that we use permanent suture, which is a polypropylene suture, which is a non-resorbable. It should be a non-resorbable suture.
Non-resorbable, yes.
Yes, and you should stick on 4 layers of repair. That is something which we explain as a key point of this technique. And the Shouldice Hospital make a publication this year about the modification or also a consensus on it. And they allow to use the polypropylene suture instead of the wire or even stainless steel.
Okay.
I've spoken a couple of weeks ago with the actual or current head of the Shouldice department, and his opinion,
yes,
to be honest,
yes,
and he totally agree with the polypropylene suture, which is the same stability, which gives you the same results as with the stainless steel. So I think the stainless steel might be something what you should, of course, replace with the polypropylene sutures.
Yeah. Yeah, that's Dr. Spencer Netto, who was a guest on HerniaTalk before.
Yeah.
I think 2 years ago, almost. You see patients like I do who react to foreign bodies more than usual. Have you seen anyone react to stainless steel suture?
No, of course, it's very unusual that we, I think there is nobody using in Central Europe stainless steel, and that's why we don't see anything. Might be there is a slightly difference, but I have never seen any patient with this so-called, and you call it, and you have made this beautiful publication about mesh implant illness.
Yes.
And or even the Asia Shoenfeld Syndrome.
Yes.
By the origin. And of course, there is slightly, in the majority of these patients have a bigger size of mesh, and not only a suture line, which is only 170 centimeter long or 50 centimeter long suture. That's a huge difference. And I haven't seen, might be that you have seen anybody with this reaction also?
No, and I think, so the only risk would be if you are nickel allergic, and I have to check, I think the stainless steel suture does not have nickel in it. There are other stainless steel products on the market that do include a certain percentage of nickel. I have not looked into it to see if it includes nickel in the stainless steel suture. I think that would be the only thing. Because I have had people.
No, we should be aware of. That's something, of course. I think, but I strongly believe that the mass of material is so low that the influence is also very low on the whole body. And normally, of course, these allergies or even Shoenfeld syndrome is something, of course, there you need even more material.
Yes, correct. Here's a question: a 70-year-old female, 70. I got a hernia doing leg presses 8 years ago. We can argue whether it was due to leg press or not, but she has a hernia just below her belly button. It's large, and I would like to know if it can be repaired without using mesh, as I'm afraid of mesh-related side effects. Actually, let me ask you this. Of course, I think there's no argument, at least between us two, that there are side effects with mesh, including reaction to mesh. But in your experience, how common do you think that problem is? Is it 50%? Is it 1%? Is it a fraction of 1%? Because I tell my patients, we don't really know, but based on my experience, it's a fraction of 1%. We don't have people running around having a lot of that. But what are you thinking?
No, of course, it might be that you and I have a very selected group of patients.
Yes.
I'm sure that we have, because we offer some alternatives, and that makes a difference.
Yes.
I have in my patient series almost, I think it's a fraction of 1%,
Yes.
not a fraction of fraction, but
Okay.
a fraction of 1%.
Yes.
So I strongly believe 0.5% of any issue with the mesh.
Yes.
Of course, they come into my practice, into my office for get any recommendation, any tip and trick, or any treatment, any recommendation how to solve this problem. And of course, you get, since some years, even more, of course, if you are even more dedicated on this issue. The old 70 years old lady, I think it seems to be she has an hypogastric hernia.
Yeah,
is it correct?
Below the belly button.
Below the belly button. And that is something which is definitely a very rare condition of hernias. If it's on the left or right side, that could be a Spigelian hernia, yes.
Yeah.
But in the, I think, suprapubic area or even in the hypogastric area is a very rare condition. Might be it's a port side hernia.
Yeah, port side or incisional, yeah.
Yeah, that could be one option. And of course, once again, it depends on the size, on the quality of tissue, and then you can make a recommendation. For that reason, I would always recommend to do an ultrasound or something like this. That would help to get even more information about it.
But in general, large abdominal hernias, not inguinal, large abdominal hernias don't do well without mesh.
No,
yeah.
I'm sure. Yeah. I think, of course, there is a big difference. I think, of course, the abdominal wall has much more pressure.
Yes.
Secondly, of course, if the size of the hernia is even not only 1 centimeter or 1.5 centimeter, or even almost 2 centimeters, but that's the limitation.
That's about the maximum, yeah. 1.5 to 2.
1.5, and almost in some selected patients might be 2 centimeters, but that is a limitation. But large hernias, I think, I don't believe that they can be fixed without any mesh.
When you see people that maybe are concerned that they're reacting to their implant, fibromyalgia type symptoms, etc., are there any tests that you submit them to, or is it purely clinical? Your diagnosis?
I think almost, of course, the diagnosis is, I think you can make some blood tests for sure, to look for, of course, this immunologic reaction on this. You can make a testing, definitely, of course, a skin test with all these. If you get the information about the used material, you can make a skin test by a dermatologist, or you do it by yourself.
Allergist, yeah.
Yes, or
an allergist.
Yes. Normally, of course, it's wise to make a consultation with a dedicated allergic doctor or allergicologist. Yeah.
Yeah, our experience with allergy testing is still in its infancy, and so far has not been very, how should I say it? The false negative rate's pretty high still. So it's not very diagnostic. Have you used other sutures besides polypropylene for your tissue-based repairs?
We use also some PVDF or even some long
suture. We don't have that.
Yeah. I think, of course, it's a German brand. And, and secondly, of course, we have almost some...
have you ever used nylon?
No, not anymore. I think we use some long-term resorbable sutures, which have a very good elasticity, like this from Brown Monomax, which is very elastic. That could be an option. I think, of course, we are looking for some comparative studies practicing the Shouldice with a long-term resorbable suture instead of I think a short-term doesn't work,
Yes.
A PDS or something like this, which is resolved after half a year, is too early.
Yes.
And normally I need some material which lasts a bit longer. I think there is some progress. Might be we wait for some new sutures.
That would be
I
great.
think the same like with the resorbable meshes.
Like the phasic, like a phasic suture?
Like phasic suture or even phasic mesh. We have used them also, and we have used the Tiger Matrix and something like this.
Yes.
There are some resorbable meshes on the market. I'm not very optimistic that they will fix the problem, or even the problem is, of course, you make a reconstruction and you add a mesh. And if you get a recurrence afterwards, you don't know what was the failure. Was it the mesh or was it your suture? I don't know.
Have you done that where you do a tissue repair, but you buttress it with a layer of absorbable mesh, like a biologic? Have you done that?
We have done some cases, not very frequently. I try to avoid it. But of course, we did some cases with resorbable biological meshes.
Yeah, I had a soccer player young, healthy guy. He had a Liechtenstein, and it was just a bad experience. Like, he had chronic pain from it and nerve entrapment. And I took out the mesh, did whatever I had to do with the nerves, and then he didn't want any more mesh. He's like, I don't want any more mesh. So I said, fine, but you're a soccer player and you have a recurrence already. Let's like 2 hits.
Yeah.
So I said, let's compromise on this. Let's do a tissue repair. But I need, in the short term, I need some extra buttressing to help scar in that tissue repair.
Yeah.
He did fine for, I think, 8 years. And then he's like, I don't know, I have this little pain here. And the imaging showed like a little tear in the tissue repair. It wasn't a complete recurrence, but by then he was okay putting mesh in. So I laparoscopically repaired it, and he's like, fine. It's like, it's the best I've ever felt. But that's my main long-term follow-up in someone where I did tissue repair plus a buttress of biologic. Yeah, scar tissue is not strong enough.
I remember one case which was really impressive, because he got, of course, he don't like the idea to get a mesh.
Yeah.
He got a previous Shouldice repair, and after 1 year already, he developed a recurrence.
Oh boy!
So it was really, really early, and he. At that time, there was a new brand, the Tiger Matrix, on the market, and he agreed using this mesh in case of course, any kind of instability.
Yes.
He got this Tiger Matrix. 3 years later, he develops again a recurrence. And once again, he tried to avoid any foreign body. And of course, so I think it was already very narrow for me. And I choose finally a Desarda repair, and it works.
Okay. Yeah. I mean, Desarda is an online mesh. It's an online biologic. You can think of it as an online biologic.
Yeah.
But it's permanent biologic. It's not an absorbable biologic.
Yes.
It's a permanent biologic.
Yes. And it's an autologue flap of your own material. And of course, I think the very good thing is that when Desarda explain the mechanism, if you pull tension on this flap, then you narrow a bit the internal ring, and you make it a bit stronger.
Like plication, you almost plicate it. Just a little plication.
Yeah. And that's quite interesting. I think, of course, he's using the crossing fibers for to understand this technique. he visualized these fibers of the abdominal wall, and the external oblique has fibers in different directions, and they are crossing almost. And this principle he used to develop this technique.
Got it.
And that makes sense in my mind.
I need to go visit Dr. Desarda. You're making me rethink my thoughts about it.
No, of course. I think he's might be very extreme because he strongly believes that we never use any, or we don't need any measures. I'm not convinced about this. I think we need measures, but we don't need measures in all patients. That's the important take-home message.
Well, can you believe the hour is over, and that's going to be our take-home message?
It's really, oh wow, yes.
Yes, can you believe it? It's 10 o'clock p.m. your time.
I believe it. No, it was very, very short.
Very short, because so Dr. Lorenz, I always enjoy speaking with you because I could talk to you forever. When I see you at the meetings, which is the only time I ever see you, unfortunately, I just can't stop talking with you. I feel like we share so much and our brain waves are similar, and it's always nice to find someone that you kind of share similar thoughts and practices with. And I always learn something from you too. So it's my pleasure to have you take time away from all the work you're doing at the German Hernia Society, teaching and talking and spending an evening with me and my audience. I
really appreciate it. I'm really thankful for this kind invitation, and definitely we will continue this communication and this debate on these topics. It's quite interesting, and of course you know my enthusiasm about this topic, and of course there will be some progress.
I do, and I feel everything we do at HerniaTalk Live is reflection of cutting edge, and we follow guidelines and we try to teach patients about what is the best level of care. And it's people like you that help push the quality of our weekly sessions. And for that, I thank you very much.
Thank you so much for this invitation.
Thank you. And thank you everyone else for your questions and your participation. This and all prior HerniaTalk Live sessions are all available on my YouTube channel at HerniaDoc. You can listen to it again, share it with your friends. I will see you next week with yet another lovely guest. And on that note, thank you and good night.
Have a good night too, or even have a good day.
Good day. This is true.
It's much earlier in your
This is true.
Okay.
Thank you. Bye-bye.